Good evening. My name is John Rooney. I'm a member of the staff at St Vincent's Private Hospital, and my colleague tonight is Dr. Horng.
Thank you for taking the time to join us this evening. I'm Horng, Acute Orthopaedic surgeon at St Vincent's Public and Private Hospitals.
Tonight we've got some exciting things to talk about, which are really directed towards the general practitioner. I think Horng has made up an excellent publish tonight, and I think I'd like to hand it over to him now.
We've broken this talk up into three sections. We'll be talking about the care plan of the patient with hip osteoarthritis, physical examination of the knee, and the post-operative hip and knee replacement patient in the GP setting. In this talk, we would like to convey a framework for approaching these topics, and we've deliberately kept the details brief to concentrate on the framework. Feel free to ask any questions, and we will have a break in between each section to address these questions. So, starting with the patient with hip osteoarthritis, John, just tell us about the typical symptoms of the patient with hip osteoarthritis.
The person's going to come in with pain, stiffness, and the inability to perform normal activities of daily living. At the same time, they may also be unable to enjoy sporting pastimes or recreational activities.
So in thinking about setting up a care plan for a patient with diagnosed hip osteoarthritis, we think about it just in three categories in terms of how we can maximize or improve pain, improve function, and improve quality of life. So going into each of these categories, in terms of managing pain, we can look into pharmacologic and non-pharmacologic methods, and John's going to go more into these.
Well, often the patient may actually already be taking paracetamol or have some old medication off the shelf from previous ailments, but they'll eventually come in and requesting analgesic relief. Often the general practitioner will prescribe non-steroidal anti-inflammatory agents in conjunction with paracetamol, cover biomedical therapy. Of course, taking into account that there's no contraindications for that type of medication. Opiate medication is probably not indicated and starting to fall from grace in most recent times. Glucosamine chondroitin, often asked question. There's no basis of level of evidence for it. That's at best level 2. That's quite a common request for that type of medication in general practice.
And what about non-pharmacologic methods?
Well, I think glucosamine chondroitin, fish oil, krill, these are very common. They're off the shelf. It's obviously something that's accessible anecdotally. Without a doubt, people find that they get symptomatic relief. I don't discourage it, and at the same time, the evidence is still out.
And does the use of walking aid help pain management?
I would say that in Australia we underutilise walking aids. In Europe and probably in North America, they're more likely to use a walking aid like a walking stick or have a brace, whereas we do not do that so commonly.
We also think weight loss is important, where achievable in managing pain.
Well, unfortunately, Australia is right at the top there with the United States and North America, and obviously Mexico as well, with obesity. We can't change our good looks, but we can definitely work on decreasing our weight, and that's something that we can all be participating. So the option for dietetics, nutritional advice should all be part of the care plan.
And we find that in a patient who's overweight, they can lose 5% of their body weight as an improvement in their pain. Now next, we'd like to talk about improving the function of the patient with osteoarthritis. Now, John, what are some of the measures that can help in this regard?
Well, we all hear that regular exercise is good for our overall health. It'll improve our muscle strength, decreases fatigability. It improves our mental wellness. So an exercise program should be encouraged, And at the same time, I think it's best when it's directed by the general practitioner or a physiotherapist. So some people, very few, can do it themselves. But so I think putting down as part of your care plan to have a regular exercise program is good.
And in the patient with hip osteoarthritis, what are some of the functional issues they might encounter?
Well, the issues that they often complain about, their inability to put on their shoes and socks, put on their trousers, their slacks, pick up the dog, get in and out of the car, the classic lifting up the thigh to get in and out, and just the inability to participate in normal activities without pain.
Yes, so occupational therapy would be use of functional aids, such as the assist device to pick up things and to put on the socks can be helpful.
Yes, it's underutilised. I think pre-surgical options of occupational therapy and physiotherapy should be encouraged as part of the care plan.
And some of the patients, the mobility might be limiting their ability to look after themselves in terms of cleaning and going out to the community. They may need some help with services.
Some services are available in certain regions, and that should be pursued if possible.
Next, we think about how we can improve the quality of life for a patient with osteoarthritis.
Well, if people are not feeling like going out of their house, it's not going to be good for their mental health. They will isolate. They will not get out. They'll miss out on their friends and family. So we want to get that kind of overall wellness, which is very much encouraged in the 21st century. And therefore, they need to understand that this is all part of the wellness and care program.
The patient may be quite worried that the mobility will continue to deteriorate and they'll be able to do less of the activities that they enjoy. It's important to educate them that it is a chronic condition and we can learn to manage this. Now, we're just going to take a break. We're just going to look into the sound. I think we're having some issues here.
Thank you for your patience, everybody. We're just having a couple of issues with the sound, which we're trying to rectify. So please, in the meantime, just send through any questions through the questions box and we'll get back to the webinar as soon as possible. Thank you.
Can you hear us talking now?
That does sound clearer, yeah.
Great.
Okay, so we can resume now. Yeah, so we'll just resume this. So we talked about quality of life, looking to quality of life and mental health assistance in a patient with hip osteoarthritis. Now, next, this is a patient of mine, and he's heard your band and is a fan of your band. Now, John, just tell us about this X-ray.
Well, it's an AP radiograph, and you can see that both joint spaces are narrow, so it's a advanced arthritis of both hips. And this person may be showing signs of pain and stiffness.
Yeah, so we talked about symptoms earlier. What would you expect to find on physical examination of this patient?
Probably walking in with a limp, inability to flex without pain, perhaps beyond 70 to 90 degrees. With the hip flex to 90 degrees, internal and external rotation will probably be limited, more so internal rotation, and that would probably induce pain. They also may be starting to walk with an increased foot progression angle, with the leg and foot more externally rotated.
So this patient has radiographically advanced osteoarthritis. Now the question would be, when should this patient come and see us?
Well, most people will come in because of pain. Sometimes it's stiffness. Rarely it's stiffness and then pain. And once again, quality of life. Someone unable to go to the shops, to walk to the normal 500 metres to the shop or a kilometre to the shop, getting out of the car to do those activities of daily living. Sports such as bowls, golf, it's inhibiting their quality of life. So they'll come in and that might be a trigger. They used to walk the golf course and now they're required to use the cart. So that's quite a common scenario, I believe.
So we talked about the non-operative management within the care plan earlier. Now, in terms of the operative management, this would be total hip replacement. Often the question is, when should the patient be having the total hip replacement?
Well, hip replacement is an elective operation. It's an operation of choice. So therefore, you don't rush out to do it. You want to maximise non-operative management, which is what we've already talked about as part of the care plan. Secondly, you want that person to understand what the problems are in regards to the natural history of the condition. Osteoarthritis doesn't get better. It's a progressive disease. So therefore, we want them to understand it, to learn to live with it, work through non-operative management, and then eventually operative management. And that's where those non-operative issues such as physiotherapy are such an important issue, in my opinion.
And just going back to that framework earlier, so thinking about in terms of pain, function, and quality of life, to where there's an established radiographic osteoarthritis, the total hip replacement is indicated when in these categories, pain, function, and quality of life is no longer acceptable to the patient with the non-operative management. So now, when a patient, we've decided to proceed with total hip replacement for a patient. For our patients in the public hospital, there is a wait list. And during this time on the wait list, all our patients at St Vincent's are now enrolled in the osteoarthritis chronic care program. And they're assessed and by a multidisciplinary team, including a physiotherapist, occupational therapist, and dietitian. And effectively, it's continuing the care plan, but within a hospital setting.
That's good. It's an excellent initiative.
Well, for patients having surgery in the private hospital, there isn't that wait list involved, but at St Vincent's Private, we do engage in prehabilitation. I'd like to invite Sean, our Director of Allied Health Services, to speak to more about that.
Thanks, Conley. Thanks, John. So here at St Vincent's Private, it really is a campus of complete care. This is a high throughput orthopaedic centre that supports the work of high volume surgeons such as John and Hong Lee. And our whole approach to understanding the factors that can affect somebody's outcome after joint replacement surgery really are centred in the hands of the surgeon and also the patient themselves. So traditionally, these factors can be divided up into modifiable and non-modifiable factors. We can't change a patient's age, for example, but we can work with patients who present with a range of comorbidities that we can then allocate appropriate resources to ensuring a better outcome. So traditionally, the approach has been that surgery is undertaken. It's a pretty predictable stressor that all patients will undergo regardless. And the two types of stresses are really physiological, but also psychological for the patient. And our approach to managing these is, first of all, there have been enormous improvements in the surgical technique and modifications over time, to the point where we can actually mobilise patients and get them up and on their feet the day of surgery if it's indicated by the surgeon and their protocol. This is like an enormous improvement in terms of what we're able to achieve early and quickly and safely for these patients in the hands of high volume surgeons working in a high volume centre such as St Vincent's Private. But also ask that we as physiotherapists start to then kick in the whole range of post-operative strategies to offset many of these very predictable effects of joint replacement surgery, joint stiffness, inability to mobilise, respiratory care, a comprehensive approach to help patients recover after the operation itself. So this is really a very reactive model of care that's traditionally been undertaken. So these things occur and then we can just go straight ahead and, and as a multidisciplinary team work together for the greater good of the patient and also the outcome. But over the last 10 years, what we've really been developing and maximising is this period prior to surgery. So this period where patients have some time on their hands and we can prepare them both physiologically and psychologically for some pretty predictable effects of surgery. So what is prehabilitation? Certainly we have a diagnosis with the surgeon, there's a surgical wait time, we undergo the surgical procedure and there's the recovery time. So it's this period of the surgical wait time that we're able to really optimise, and the surgical pathway starts way before the skin to knife actually takes place. It's all led by the surgeon and the consultants. It's their plan of management, and it's something that we follow through carefully. It's a period of active treatment. It's a bundle of care. It can be multimodal. It's very patient-centered according to what's required. So what does that look like? Ultimately, the goal with these interventions is really to enhance the recovery for the patient. It's to make the journey better. So the analogy that we've often used, it's like flying from Sydney to New York. You can either fly in 1A or you can go up the back of the bus for a very round trip through the long way around. Certainly you can get to the same end point, but your experience is extremely different. So for these patients prior to surgery, we have this teachable moment. We have this captive audience where people are willing to listen. You'd agree, guys? Yes. Yeah. And certainly the improved nutritional status is something that can be able to be flagged early on for our patients. Enhancing quality of life and reducing anxiety prior to surgery is one of the aims of this program. So it's not just physical, it's actually psychological, where we ultimately want to try to increase someone's cardiorespiratory fitness to reduce the risk of surgery, certainly get some low limb strength gains, but also to develop some pretty realistic expectations about what's likely to happen. The net gain for us is we've really been able to reduce our length of stay, which has a number of advantages for the patient, and also really ultimately a better experience, which is often described as a better patient outcome. So the basis behind this is patients walk in the door with a baseline level of fitness. Those who don't undergo prehab, the surgical stress that still occurs, they go through a period of rehabilitation and they improve. Certainly with prehabilitation, the whole purpose is to increase someone's functional reserve. That includes their resilience as well, by them understanding what is about to occur. The surgical stressor again is exactly the same, but the trajectory of the recovery. So theoretically, this is what it should look like. So how's it delivered? It's really centered around functional aspects, exercise prescription, medical optimization, some nutrition wherever it's indicated. That's both, reducing calorie intake and increasing calorie intake wherever the case is for the patient. Certainly some lifestyle choices are able to be changed. And again, stress management for those patients who really are quite anxious about what lies ahead. These programs can take a range of different, the structure of these programs are very patient-centered. These are the tertiary referral centre. Patients come from everywhere to get operated on here at St Vincent's Private with John and Horng Lee. So we have to adapt the model to suit the caseload. Certainly COVID has drawn us kicking and screaming into the telehealth era, which I'm sure general practice has been part of that process. So there's a new skill base and an ability to undertake these interventions according to what is available at the time. Certainly it's supplemented with written materials. A lot of patients remain visual learners, telephone follow-ups and some messaging as well. We also like to treat crutch walking before the operation, so patients are aware, and it's a new skill for many patients and also cuts down the risk and makes it easier for them post-operatively. Certainly the content of the program can involve a whole range of different patient-centered approaches, which is really symptom limited according to how the patient presents. Also, the range of comorbidities that we see is quite striking in this patient group as well. So ultimately, one of the mantras that we like to see is more prehab to avoid, some less rehab. And also some innovative strategies in the NHS in the UK where patients have to go to surgery school before they even front up for their operation, I thought was pretty cool. So again, here at St Vincent's Private with John and Hongley's joint replacement program, we follow in line with a pretty comprehensive program to ensure that patients who do come to the hospital are offered a package of complete orthopaedic care.
Thank you, Sean.
That's great.
So, come to the end of this first section. Now, we'd like to open up some time for questions.
Okay, we've got a few questions that have come through. How much does pre-op rehab play? Sorry, how much of a role does pre-op rehab play in public and private settings?
Yeah, so I'll just answer first in the public setting. So there's the OACCP program, like we said. Now that again has been affected by COVID as well. But we do have data to show that patients who've been on that program for 6 months in the public setting do have a reduced length of stay. Now, for a private setting, I'll have Sean answer that.
Yeah, look, patients eat this stuff up for breakfast, to be truthfully honest with you. Patients want to increase their locus of control. They want to be part of, they've made the decision to have the operation and they want to be actively doing something to prepare. I think people's understanding of preparation, instinctively it makes sense. Certainly a lot of sporting analogies help. You don't front up to the Olympic Village if you're going to the Olympics and try to work it out. You actually prepare for anything that involves some sort of physical challenge. So it's comprehensive according to what the patient needs and according to what the surgeon's expectations is for the program itself. So again, it's very patient-centered. So the patients that we get from the New England area, for example, who travel a long way to have their operations here, we have to treat them to get the same outcome, but in a very different way.
I think the point to make is that prehab is equally, if not more important than post-operative rehabilitation. And in a perfect world, if a person can undertake prehab, I think they'll be much more comfortable about their decision to go through the whole journey of having an operation.
I think that the realistic expectations for different patients, because the expectations can be a little different for different patients, yeah.
Okay, great. The next question is, can you explain the different types of injections as analgesia? Analgesia.
Yeah, so in terms of injections, there's cortisone injections, there's hyaluronic acid, and there's PRP injections. In the setting of hip osteoarthritis, my general experience is that the injections are not that helpful. Sometimes we do use a local anesthetic and steroid injection to the hip, but that's often more as a diagnostic injection to help. In some patients have a more complex pain profile. There might be multiple sources of musculoskeletal pain. Could be there is hip osteoarthritis. There's also lumbar spine issues. There may be knee problems, and sometimes we do use that injection to help us prognosticate how effective intervention on the hip might be on their total pain picture. But certainly, my experience is that these injections are not a useful long-term solution.
Yeah, I think they're a short-term option because sometimes, even with the local anesthetic, the patient will have complete pain free, let's say for 12 hours, and they then realise how much pain they've been experiencing. So added to the diagnostic issue, it also makes them realise, you know what, I don't need to live with this pain. If I have a successful outcome from my total hip replacement, I'll be very happy. And it's best exemplified by one patient from the bush who had an injection, and I saw him 6 months later and I asked him how long the injection helped him. He said 5 months. Can I have another injection? and I gave him a prescription for another one. Saw him 6 weeks later and he said, can I have a hip replacement, please? So that's how he came to that decision.
Yeah, there's an evidence review. I've had a look at the ACGP guidelines on osteoarthritis for hip and knee, and something for the hip. There's not much. The evidence does not support the use of hyaluronic acid or PRP in hip osteoarthritis.
Okay, great. The next question is in 2 parts. So if the prosthesis is loose, what should be done, and how long will the total hip replacement prosthesis last?
So, sorry, the first question was if the prosthesis is loose,
what should be done?
Yeah. So we'll be coming to that in the later part of the talk. But if a prosthesis is loose, that will generate symptoms of pain and reduced mobility. It can go on to lead to fracture or instability of the joint. So generally, it needs a revision of the joint replacement. Now, we'll have to look into whether the loosening is because of infection or whether it's aseptic loosening. The only time when revision is not indicated is probably a patient with multiple medical comorbidities where the lifespan may not be as long. Now, the next issue in terms of how long do prostheses last for?
I think most surgeons would probably quote 15 to 20 years these days, and the operation takes about 2 hours from the time the incision is made to the time that the wound is closed. I think that would be an acceptable answer for both of those parameters.
I think there's this revision rate within 20 years. And a lot of revision now, I think, is for a variety of other reasons, such as infection, fracture, instability. Revision for wear is not so much a problem anymore. And I generally tell my patients that with current materials, we expect it to easily last 30 years or even more.
Great, thank you. Okay, I think we can continue with the presentation.
Thank you. So in the next section, we want to cover physical examination of the knee. We've broken this down into 3 scenarios as well. We didn't want to go through a full examination like how we might do it, but we wanted to present it in 3 scenarios where the patient might present to the GP's office. And the components of any examination, just to keep it simple for us orthopedic surgeons to remember, is look, feel, move, and special test. And I've just put a clinical picture up here of a patient in both knees, just to show how useful it is to have the contralateral limb exposed as well, to be able to compare the 2 sides. So you can see here on the patient's left, the patella is sitting much higher, and that's quite obvious when you compare it to the right knee. And there's the on palpation, you feel a defect inferior to that patella. This patient has a chronic patella tendon rupture. So from going through look, feel, move, and special tests, during the examination, we want to gain information about the status of the bones, the joint structures, in particular things like the ligaments, the meniscus, the muscles and tendons across the joint, the bursa, the neurovascular structures, and the skin and subcutaneous tissues. So in the 3 scenarios, I've broken this up into firstly, acute knee, which I've termed the angry knee. So this is a patient who's had a sudden flare of symptoms, and usually with a history of trauma. So we're going to try, we've recorded this video beforehand. I'm just going to play it now, and John's going to talk us through it.
So we're looking at this patient here, one of our excellent, outstanding staff from the Horng's unit, and we can see that they've got their right knee flexed. They can't straighten it. They're in discomfort. We ask them to walk. They've got an antalgic, painful limp, and they're not particularly comfortable. Here you can see Horng Lee. He's just starting to feel for any temperature changes. Look for any areas of skin breakdown. Now he's feeling for any tenderness. So he'll probably start, he's going to start to passively try to extend the knee out to full extension. The patient does not want to do that. He's feeling the lateral side of the knee. He's just performing the swipe or wipe test to see if there's an effusion. He's now obliterating the suprapatellar pouch and trying to ballot to do the patella tap for a moderate sized effusion. Once again, looking at the patient's face, see if there's any discomfort. And now he's palpating the quadriceps tendon insertion, asking if there's any pain, the patella and the patella tendon itself. Feeling for any tenderness over the hamstring, biceps, femoris down to fibular head, medial joint line, medial collateral ligament, down to the insertion of the hamstrings. Always asking if it's painful. Now, Horng Lee's just asking.
Sorry, I think the video's just had some videos not playing quite smoothly. Let me just try that again. I might just let it run from here.
Yeah. So now he's palpating, as I said previously, over the extensor mechanism. Because you have to be worried about quadriceps tendon tear, patella fracture, patella tendon issues.
Sure, there's still issues with the video running.
Once again, feeling for tenderness. Horng Lee's now assessing how much he can passively flex the knee. You can see it's about 20 degrees at flexion. He's now starting to move it passively. It's grimacing on the face of the subject and only gets to 70 degrees. So the arc of motion is extremely little at 20 to 70, so it's 50 degrees. So this right knee is definitely uncomfortable in an acute setting. So in the angry knee, the history will tell you what you're starting to have to look for. You know, if it's infection, you might have a history of penetrating injury. They may have had travels from overseas. They may have had a traumatic event with a stumble, indicating that there might have been an issue to the patella mechanism, whether it's a patella fracture, patella tendon or quadriceps tendon rupture.
Yeah, so in this scenario, the information that we get from the examination is limited, but the main features that we're looking for is the patient has a marked limp, they are unable to weight bear, the knee is held in a flexed position. We look for erythema and bruising around the knee. We feel for there's generally a large effusion, or there can be diffuse swelling about around the knee. The knee tends to feel warm. And movement is very limited and with severe pain with any attempt at range of motion. We're not able to do any special test. So the conditions that we want to exclude here are fracture, dislocation, infection, in particular septic arthritis, and then quadriceps or patella tendon rupture, as these are the conditions which will require urgent referral, and this would usually be via the emergency department.
I think the important thing to remember is that neither you nor the specialist will be able to examine this knee very well at all. So don't be disappointed about that issue.
In this scenario, the investigations that we usually get would be AP and lateral X-ray of the knee. Where possible, we'd like a scar line as well. Although often when the knee is acutely inflamed like that, it's often too difficult for the radiographer to position the knee for a scar line view. In some situations where we're suspicious of a fracture, which is not easily seen on the X-rays, there may be a need for a CT. And when there's concern of infection, we check inflammatory markers and we do Rooney aspiration. Now we'll go on to the next scenario. Now we're just going to change USB over just to get the video uploaded, play more smoothly.
So here we've got the subacute injury.
Sorry, John. I'll just make sure that's running as a slideshow. Keep it like this. So the next scenario is a patient who often has had a sporting injury and presents a couple of days later to the practice. And the most common conditions often there may have been an ACL rupture or patellar dislocation, but we just want to go through the examination here, as there may be more special testing involved. So we've done the inspection of the patient in the stance phase and the gait of the patient, and here John will talk through the rest of the examination.
So here's Horng once again examining the subacute injury, often sporting. Person's a bit more easy to examine, but still in discomfort. Once again, he's seeing how much assessment of passive extension. He's now going on to examine the extensor mechanism and palpate the areas of tenderness. He's doing the wipe and swipe test for a smaller fusion. He's obliterating the suprapatellar pouch. He's doing a patellar tap for a medium-sized fusion. And the cross fluctuation for a larger fusion. Once again, you can see the patient's holding your knee slightly flexed. He's now palpating. And now he's moving on to passive flexion. You can see here the patient's about 10 degrees off full extension, so a bit more amicable movement there, and now passively to 90, so a bit more arc of motion. Horng's now kept the knee there at 90 degrees, and he wants to assess the contralateral limb. Easily moves to 140 degrees, full extension. And now he puts both knees to 90 degrees, puts the heels together, and he's comparing them. Palpating for tenderness over the lateral joint line with his left thumb there, as you can see, and then over the medial side of the knee, and now over the fibular head. On the medial side, he'd be looking for the medial collateral ligament from its proximal and origin and insertion distally. Now the medial joint line. Always looking at the patient's face, making sure that you're not causing any discomfort. He's now looking for any posterior sag. between the relationship for the femur and the tibia. If the tibia has a PCL injury, the tibia will be translated posteriorly. That's what he's looking for. He's kept the limb at 90 degrees. He's now politely asking them to sit on their feet, and he's going to now assess for the anterior draw and the posterior draw. He's trying to take up the tension of the hamstrings here with his fingers. He's pushing backwards to feel a firm end point for the PCL and an anterior draw with a firm end point, noting if there's a soft end point or if there's any anterior translation. Whilst he's got her there comfortably, he brings the leg up into his arms to now assess for either a varus valgus force to the knee to see whether valgus force, if the medial joint line opens up for a medial collateral ligament injury, or a varus force applied to the knee to see if it opens up laterally. And then at the same time, he'll probably perform a Lockman's test, if not already. Looks like he's about to perform a pivot shift, which is often not something we can comfortably do for the patient, normally under an anaesthetic. He's now trying to provoke the medial meniscus. He's flexed the knee up and trying to see if he can palpate on the joint line for any medial meniscal tear, induced pain, or any provocation or any extrusion. He's now performing McMurray's test, trying to entrap meniscus or a loose chondral fragment and induce pain. He's bringing it out into extension, which is still about 10 to 15 degrees off full extension. And you can see in that test and examination, he could do a lot more than the original test.
So in this scenario, the relevant findings we would be looking for is looking at the knee held flexed. The patient has a limp. Now we've put quadriceps wasting down here, but that might be a couple of weeks before that starts to show. We want to look at the patella position and the tracking of the patella. There's usually a bit of fusion. We want to know specifically the location of the tenderness relating to the anatomical structure. And we want to assess for patellar apprehension. And with the range of motion, we want to know whether the knee locks, whether there's a physical block through extension of the knee, and whether there's restricted flexion. And where flexion is restricted, this is usually due to pain. We want to know whether the pain is at the end range or whether it's through range. Special tests, John's mentioned most of these in the video. Specific tests for ligamentous structures. For the ACL, the tests are Lockman's, anterior draw, and pivot shift. For the posterior cruciate ligament, we look at the tibial sag, a loss of femoral tibial step-off, posterior draw, and quadriceps active tests. With collateral ligaments, we look at the valgus and varus stress at full extension at 30 degrees. There are some more specific tests for the posterolateral corner, but we won't, for the purpose of this talk, we won't go into that here. Now, for the meniscus, there's a variety of provocation tests described. What I do find most helpful is palpation or tenderness, specifically in the joint line. And with acute meniscal tear, there's often you can feel a fullness at the joint line there as well. Look for difficult inability for the patient to squat. I do Tesley's test where the patient stands on one knee and has the knee flexed, and I pivot the patient on that knee, looking for pain. I do try to do McMurray's test as well in some occasions where the diagnosis is still not clear, but ultimately in a lot of patients in this scenario, it can still often be difficult. Sorry, just skip the slide there. It can still be difficult to tell from the examination what the exact diagnosis is. So apart from the relevant x-rays, we do often want to bring the patient back for another examination when the pain and swelling is better, or we may require an MRI. So the conditions that we look for which may require early referral to the orthopedic surgeon is a patient who's had patellar dislocation. Patella is now relocated, but there's been an osteochondral injury. Patients with a ligamentous injury, and the patients that we want to see early in particular are patients who have had a multi-ligament injury or a tibial-sided rupture of the medial collateral ligament. A meniscal tear in a young patient where meniscal repair is considered. And this may be a bucket handle tear which is displaced and the patient may present with a locked knee. The locked knee can also occur because of osteochondral fragments, and this can occur with a patient osteochondritis dissecans. And I've just put this in that I would like to see this patient early as well with osteonecrosis or insufficiency fracture. It's a subacute presentation. So in the last scenario, in the patient of chronic knee pain, call this the sad knee, and we're really constant for the purposes of this scenario. We're concentrating on the patient with suspected knee osteoarthritis and examination of that. So John's going to talk us through that.
So the osteoarthritic knee of long scanning, you'll be looking for muscle wasting, particularly in the quadriceps or the calf musculature. You'll also look at the alignment. Neutral physiological valgus may change to either a valgus alignment, knock knees, or a varus alignment, which is a bow leg. You can see here we've got some valgus deformity there, which is great by our subject. And then just for contrast, they're going to give you a little bit of a bowed varus alignment. There they go there, dynamically. Looking from the side, once again, the posture of the flexed knee. And you can see how things have changed also in the lumbar spine. Looking at that overall sagittal alignment. Now gait and pterygic limb. Which will be a short stance phase, pain relieving gait. Here, Horng's have them seated. He's checking for fine patella crepitus. So fine crepitus implies osteoarthritis. He's also checking out the strength of the mechanism of the knee, and that might be limited because of pain, so it might be grade 4 rather than grade 5. He's feeling the bulk of the quadriceps as well, and most importantly, comparing it to the contralateral asymptomatic knee. He would also know the patellofemoral joint. Whilst considered internally rodent thigh to see if there's irritability of the rib, which may be referring some pain to the rib. And as for to the extent of flexion deformity, so he's unable to passively increase it. It's been probably progressing like that over a number of years. He's now flexing it, and the chain's 90 degrees. So it's irritable, but it's not as irritable, obviously, as the angry or the unhappy knee to some degree. Compare it to the contralateral limb, 0 to 140 degrees without any issue at all through the whole arc motion. Once again, look, feel, move. He's palpating for any tenderness over the lateral joint line, over the patella, over the fibular head there. Once again, on the medial side, it's an anatomy lesson. Medial femoral condyle, medial joint line, medial tibial plateau, medial collateral ligament from its origin to insertion, hamstring insertion as well. As Horng's done before, but this time perhaps a bit more comfortably to some degree because of the chronic issues. He is applying a varus valgus force in full extension and then also again at 30 degrees, just to note that the collateral ligaments are more dependent at 30 degrees of flexion as compared to full extension. What he's doing here is assessing, undertaking a neurovascular examination for all examinations of the lower limb. So palpating the pedal pulses, post-tibial pulse, torsalis figures. Now we're just checking the power of ankle extension, dorsiflexion, plantar flexion at the L4-5 termitone, and assessing a similar sensation as well. Just a gross examination.
So in this situation, the examination findings we're looking for deformity and the gait of the patient. And throughout the examination and the consultation, we can often gain an idea of the function of the patient. The examination would have started even before the formal part of the examination, such as watching the patient get up from the chair in the waiting room. There's often startup pain and difficulty. And also, for example, for them getting onto the examination couch, there can be difficulty with that as well. In terms of feel, we assess with effusion. We do expect generally to find at least a small infusion. And as we want to know that the tenderness of the tender area reproduces the patient's pain. As we talked about in the hip before, there are some patients where there can be multiple areas of musculoskeletal pain. We do want to be able to localize that the pain that is presenting does indeed correlate with the arthritis in the knee. In terms of move, we want to assess the range of motion of the knee. With arthritic knee, the natural history is that the knee will progressively become stiffer over time. And we want to assess the stability of the knee as well, in particular the collateral ligaments. So in this scenario, we mainly talks about arthritis or the arthritic knee. And we've got some x-rays of the patient here. John, would you like to look at this?
Well, I'm glad I'm not doing the operation on the right, for the right knee. You can see there's advanced arthritis of the medial and lateral compartment of the left knee, whereas in the right knee you've got advanced arthritis, and now you've also got coronal subluxation. So going back to what Horng said before, the collateral ligaments on this right side would be significantly compromised and probably ineffective at all. And that would have to be taken into account for the surgery that you would plan for the knee replacement.
Yeah, so what would you find on examination of this patient? You've mentioned the collateral ligaments, so something we assess for any deficiency of that. How else would the patient?
Well, this person would be standing in there, so they have a bow leg bilaterally. They would be in a lot of pain, I would expect, when they walk into the consultation. It would be short strides, more like a shuffle. If they did have a longer stride, they may have what we call a varus thrust, which basically indicates that the medial compartment is worn more than the lateral compartment, and therefore there is an attenuation of the ligamentous structures in the coronal plane. I would imagine that both knees are stiff, with fixed flexion deformities and limited range of flexion, and I would imagine that they would be extremely irritable, or sometimes not particularly irritable, just plain stiff.
Yeah, so I did indeed do hinge knee replacements for this patient. So the standard x-rays that we would obtain in this situation, weight-bearing AP x-rays. As you can see here, you can see my mouse cursor on the left here. A Rosenberg view, which is a 30-degree flexion PA view of the knee. You can see here that the notch is clearer that reflects the 30-degree flexion PA, and it can show the arthritic where the arthritic changes more on the flexion surface of the knee, and there can be more loss of joint space there. This can often be, particularly in a valgus knee, the arthritis may not be that significant on the standard AP view, but on the Rosenberg view it can be a lot more striking. And then in the lateral view of the knee here, we can see this patient has patellofemoral arthritis here, the osteophytes there. And the skyline view, we can see this severe advanced lateral patellofemoral disease with complete loss of joint space there. So not sure how well this section has come across. We've had issues with the videos, and it's obviously difficult to show examination in this setting. And I just want to bring up here that what is your experience like examining a knee in telehealth?
It's challenging. I think the history is important. The history often tells everybody everything, perhaps 90% of the time. And you will ask them to stand, move around, point to where it's tender and where it hurts the most. And I think history, the verbalization of the person and pointing is very helpful. You can't assess ligaments, but you can assess arc of motion, what the posture of the limb is, particularly obviously from the taken acute or chronic setting. It works. You've got to be a bit patient, but if you listen to the patient, they will tell you the answer.
Yeah, and so the telehealth physical examination and telehealth is it's difficult. It's really just inspection, and the technology can be an issue, such as the lag that we saw in the video here. But I can try to get the patient to stand back so that at least I can see both knees, so we can have a comparison to the other side. Try to have a look at them from the front and ask them to turn and look at the side, seeing whether they're holding the knee in the flexed position, and ask them to try to see if they can stand on one leg, to see if they can stand on that side, and whether they can squat down, and that can give them an idea of the significance of the issue. As best as we can, I try to get them to walk and watch the gait, so that it depends on how far they're away they position their phone or computer in terms of what information that we can get. And then I do ask them to point specifically at where they feel the pain, to try to localize it as much as possible. And as John mentioned, we look at the arc of motion in terms of the extension and the flexion range that they can achieve. That, if I see a patient via telehealth, that may give me an idea how urgently I need to see that patient. But almost invariably, I have to see them and assess them properly at some point. So are there any questions?
We do have a few questions coming through. The first one is, what is the treatment of osteonecrosis of the patella from the injury to patella in a replaced knee?
Yeah, so this is an uncommon condition, but it can happen where the blood supply to the patella is affected. And in terms of the treatment, it depends on how severe and how symptomatic it is, and whether the patella has been resurfaced and whether there's any loosening of the component there. Quite often it can just be a radiographic finding, and as long as there's no loosening of the component, we just watch and observe and do serial follow-up and X-ray examination.
It's a really challenging, it's a great question and a very horrible condition to deal with. Often it's not really symptomatic. That's the first point. Secondly, serial X-rays, as Horng said, is there an implant in there in the patella or not? At the extreme level of surgery correction, there is an implant that can be put in, which I have ordered one once but never had to use it, thankfully. And secondly, there is a paper out of the Mayo Clinic by Alan Anson, Hansen, where you can bone graft, and as they would describe it, making it like a pita pocket, PIDE pocket, where you can bone graft and like a pouch. It's an extremely rare event. And then the worst case scenario, you could do a patelectomy. The patelectomy will result in chronic anterior knee pain, recurrent effusions, and a loss of probably 20% of muscle strength of the extensor mechanism, and a very disappointed individual. But historically, 30, 40 years ago, probably 40 years ago, a fractured patella would be dealt with a patelectomy.
Yeah, so we don't have a specific treatment for the osteonecrosis per se. It's more about how much the extensor mechanism is affected and whether we need to reconstruct that.
Okay, thank you. What is the best way to manage Baker's cyst in someone who's presenting with acute onset pain and restricted mobility?
John?
Oh, the Baker's, it never ends. So it's obviously uncomfortable. Non-steroidal anti-inflammatory agents, if they can tolerate it, they're contraindications from the cardiovascular point of view or renal issues. Cortisone injection would be my first option, targeted intra-articular by the radiologist, and to reassure them it will settle, and good pain control, and then off for physiotherapy, because the Baker's cyst is a consequence of the degenerative process in the knee. As I tell people, it is a consequence of that your knee is wearing out, that there's something going on.
Yeah, I agree with that. We treat the condition underlying in the knee, which is causing the inflammation, which feeds into the Baker's cyst, rather than targeting the Baker's cyst itself per se. So we're really assessing for what is the condition within the knee, which is causing the Baker's cyst, and addressing that condition specifically.
Okay, thank you. In acute presentations, does it help the patient to aspirate the patellar effusion, or is it likely to reoccur?
So in the acute, so we're talking about the acute scenario that we put up there. Often, firstly, it can be in the trauma with post-traumatic situation. There may be a large hemarthrosis, and if the patient presents early enough within the day or so, I do find aspiration of the hemarthrosis very helpful in relieving pain. There will be reaccumulation to some extent, but just decompressing a tense hemarthrosis does help in pain. In terms of effusion from a meniscal tear, that may not be as helpful. So if it's a tense effusion, which is painful, we might aspirate it. But if it's a small effusion, I would leave that. John, would you agree?
I agree with that.
Okay. Is it true that medical meniscal tears can be managed without surgical intervention?
Great question. Historically, senior orthopaedic surgeons, let's say 10, 20 years ago, would perhaps end up taking that person to surgery for a partial meniscectomy. Recent literature in the last 10 years or so has demonstrated that a middle-aged to older medial meniscal tear, so it's a degenerative medial meniscal tear in association with some arthritic changes, can be often managed with analgesia, anti-inflammatory agents, physiotherapy, and that little speed hump that they're experiencing does settle down, and it does. Now, it doesn't always settle down, and everyone's different, but we are finding that the majority of people do, but occasionally they don't, and then your hand may be forced to undertake a partial medium mastectomy under an arthroscopy. But the point is, it does not change the natural history of that knee, which is now starting to degenerate, and that's where that answer comes into it. Would you agree?
Yeah, so I think it depends on the context of patient with the meniscal tear. So where it's a meniscal tear in the arthritic knee, where the meniscal tear is found as part of the degenerative process, and I do think that that patient can mostly be managed without surgery. But in the younger patient with a non-arthritic knee and it's acute tear, the consideration is whether it's a tear amenable to repair. So we might look at the location of the tear, whether it's in the periphery, whether it's in the red zone, whether there's good blood supply, the size of the tear, whether it's a longitudinal tear, whether we get to the tear soon enough. In those patients where the patient may need surgery to repair the tear, or say if it's if it's a large flat tear which is not which has been there for a while and it's macerated and it's in the white zone, it's not really repairable. But in the young patient, a non-arthritic knee, it can be causing mechanical symptoms, and the patient does often come to surgery then.
Okay. How do you decide if a meniscus injury is treated by physiotherapy or it's immediately referred for repair?
Yeah, so coming back to those issues, it's if it's a degenerative meniscal tear in the patient with arthritic knee, then definitely the management would be physiotherapy first, and there's no need for any urgent surgical review. But if it's a young patient who's never had any symptoms in the knee, had an acute injury, as at the examination findings that we showed in the subacute section, is locking at the knee, inability to squat. Those are the situations where we'd like to see the patient earlier to assess whether meniscal surgery is indicated or not.
Certainly for the physiotherapy management of those patients, an exercise-based approach to treatment rather than passive treatments is clearly indicated. And it's avoiding passive, non-effective interventions, essentially.
Okay, I think that's all the questions for now. We can keep on going.
Okay. So we come to the last section, and we're looking at the patient who's had a hip or knee replacement and presents to the GP office. Let's talk about it within the first 3 months of the joint replacement. And in terms of assessing what is going on, I guess it's important to have an idea of what is the usual recovery from the joint replacement. It's going to be different for every patient. It often can depend on their preoperative status and function and their other sources of musculoskeletal pain. But just to give you a rough idea, John, just say we'll start with the patient with a hip replacement. So I've thought about this section in terms of for you to look at to assess for any wound issues, assess the pain and mobility, and any specific joint issues. So just having this framework in mind, so wound, pain and mobility, and joint issues. John, can you just describe what the usual process is for a patient?
Okay, well, the wound should be pretty quiescent, pretty quiet by about 2 weeks. Whether it's dissolvable sutures or staples. There's a certain amount of swelling around the hip and there'll be some bruising perhaps. You should look for redness and obviously, you know, erythema, that's perhaps more looking like cellulitis, be concerned. If there is a discharge from the wound itself, which may have started and dries up within 24 to 48 hours, well, that's better than a continuous one. Then you have to think about, is there any constitutional symptoms of malaise off their food, temperature, night sweats? This is all naturally thinking about infection. Looking at the wound itself, is there apart from the redness, is there a stitch granuloma? Is there a little abscess there? And I think they're important things to visualize straight away in regards to the wound.
So coming back to what the usual patient, what the typical patients, so we're not looking for the problems. What do you see if a patient after hip replacement, let's say talk about pain and mobility, what's the usual progression in pain and mobility in the first 6 weeks after hip replacement?
I think it would be generally accepted that most hips are happier than knees. They should progress very quickly from 2 crutches to 1 crutch to a walking stick, independent of whether they've had conventional posterior approach or direct anterior approach. They should be going in confidence with their mobility, and they at the same time should be having a significant decrease in pain for the hip within the first 2 weeks. So at the 6-week mark, I would expect the majority of people with a hip replacement, and I'm sure would have an opinion strongly than mine, seeing everybody's hips in town, that the person should come back into, whether it's the general practitioner or the orthopaedic surgeon's rooms, feeling pretty comfortable regarding their pain and their mobility. Sean?
Yes, certainly early on after joint replacement surgery, pain management is an important part of the care that patients receive here. And that is a lot of self-management as well, and avoiding aggravating factors, which we would know would be provocative. Certainly the functional gain is extraordinary in the first 6 weeks. We see great gains in people's ability to walk, their walking distance, start to undertake regular exercise programs by the 6-week mark, and the turnaround is remarkable. Yeah.
Okay, so when we think about what categories of after joint replacement can be a problem, we can think about it in terms of the wound, prosthetic factors, joint function, neurovascular issues, and venous thromboembolism. So talking about wound issues, things which can be a concern sometimes, are bruising, blisters, stitch abscess, erythema, warmth, discharge, dehiscence, and ultimately the main thing we're concerned about is whether there's infection, in particular deep infection of the joint. John, can you talk more about some of these things and their significance?
Well, bruising occurs whether the surgeon's used a tourniquet or not, and that will resolve. It may manifest itself and track all the way down to the ankle. Blisters can occur just like fracture blisters. You may have a little bit of blistering which settles. Stitch abscess, quite common, I have to say, and everyone does their best for that not to occur, but little stitch abscess might have a little pustule. It may just have a little volcanic granulomatous reaction as the epidermis tries to envelop the stitch to then degrade it. Erythema and warmth. You can see here on this person's right knee as you look at the screen, there's some erythema around the wound, but that doesn't worry me at all at the moment. And I would obviously feel that would be warm. Discharge is obviously a cause for concern, particularly if it's cease. Dehiscence, of course, is often traumatic, and infection is always in the back of their mind and at the front of their mind as well.
Yeah, so generally with wound issues, basically if there's any concern, as the surgeon, I'll like to know about it and be able to review the patient. So in this picture I've shown here, this patient who's presented to the hospital emergency department. He's within 2 weeks after his knee replacement. Now, when you see a knee like that, you can see that it's swollen. There's redness around the wound line. Doesn't appear to be any dehiscence. How would you assess this patient, John?
Well, first of all, he's obviously does not have good skin. You can see there from his champagne legs, he's hyperdermatosclerosis, so he's got venous hypertension, that brown staining of the hemosiderin, and you can see his skin is not of great quality. I can see at the proximal part of the wound there's a little bit of elevation, maybe a little stitch granuloma forming, but at 2 weeks I'm not concerned about this gentleman. I still ask him how he's going in regards to pain. Pain would be the guide for me here. Is his pain decreasing or is his pain increasing? And once again, is there any concern? Was there any discharge? Did he feel constitutionally unwell? Did he have a temperature?
Yes, it can be hard to tell just from this inspection here. The history and the rest of the examination is very important. So something if there's increasing pain, there's increased difficulty walking, having a fever, and on examination, this range of motion is markedly reduced. It's painful to move at all. John, you'd be quite worried about that.
Yeah, I would be. Yeah. It's good because some infections, and let's say this is a deep infection, an early deep infection, with a staph epidermidis, they may be quite indolent, so they may just rumble along and not be happy. So it's always nice to, if I had any concerns, I would do a full blood count, ESR and CRP. I do that. It's a bit old school with adding the ESR, but I do like to do it, and I like to see them settle down.
Yeah, so with a knee replacement, there can be a lot of inflammation around the soft tissues, and there can be erythema along the wound line. And the point is that it can be hard to tell. Personally, rather than the patient just being started on antibiotics, I'd rather see the patient and review that.
Yeah, totally. If any general practitioner that has referred to me, I would want to know about it, and I want them to give me a call. Often in this day and age, people send photographs. I'd want to see this gentleman as soon as possible, and I'd have no hesitation to see them at the earliest point. Telephone call immediately, or text.
So this is a photo here that we've tried to show that there's a well-healed incision line, and then there's a little punctate area in the distal extent of the wound. So we're trying to show a stitch abscess here, which is not that uncommon. So the general history is that the patient has absorbable sutures. The wound's healed in the first 2 weeks or so. There hasn't been any issues with the wound. Around week 3 or week 4, as the absorbable suture knots undergo hydrolysis and dissolve, it generates a little bit of acute inflammation, and that can present with a little pustule. It generally tends to be towards either end of the wound where we put a knot. And then there's a little discharge at the pustule, which can have a little amount of purulent material, but it tends to be a discharge just for that one day. Or if there are some remnant suture material in that, it can last for a couple of days. But it shouldn't be large volume. It should generally in this situation. John, how would you manage a stitch abscess?
It's common, and the person might say, I put it at the general practitioner, put a little dressing on it. got a little bit of muck on the dressing. I want to see this person again. I probably historically would have started them on antibiotics. That would not be uncommon, and the general practitioner or any practitioner would not be wrong. I just want to keep an eye on it. I'd ask them how they are, and they may give me the history. As I said, a little bit of muck came out, but it stopped. So I go, great, I'd reassure them, and I'd see them again in another week or 10 days, or ask them to call me if it changes in the reverse direction.
And if there's any remnant suture material which is still dissolving, taking that out can often hasten the resolution of the process. But naturally, as the surgeons would be a lot more comfortable doing that ourselves. Now, what is the concern, John, that this may not be a stitch abscess? It could be more than a stitch abscess. What would make you concerned?
If it got worse, so it got bigger, started to discharge, and be continuous in its discharge, so that's going backwards, increasing pain, increasing erythema. This erythema that's around the stitch abscess distally starts to propagate proximally. So it's telling me that underlying is it's greater manifestation of the pathological process. Person's becoming unwell, increasing pain, decreasing range of motion, decreasing mobility. I mean, Sean, you would see this, you know, in post-operative physiotherapy and rehabilitation.
Yeah, certainly a number of comorbidities can also help to determine whether patients are likely to have skin breakdown or issues in relation to wound healing, and those patients are generally flagged preoperatively and managed carefully as well. You both are very accessible surgeons, so to send you a text or send you a photograph, give you a telephone call is a really easy thing to do in this day and age without feeling like we're interrupting you. So you embracing those forms of communication and having a clear line to surgeons is really the key to making sure that this doesn't escalate at all to anything other than everybody working together to get it fixed.
Yeah, no,
It doesn't happen often, but when it does, it's good to have everyone on board.
Yeah.
Okay, now we've got another clinical photo here. John, would you like to tell us about this?
Well, this is disappointing. This is a wound dehiscence, as you can see there in the proximal part of the knee, the left knee replacement. And I would imagine this has been a traumatic event. Someone stumbled and fallen on the street, and it's just simply burst open.
Yeah, so this patient had a well-healed, well, had a wound which was healing for about 3 to 4 weeks, and they had a fall directly onto that knee and presents with this. How would you go on to manage that?
I would, obviously, if they came to the general practitioner's rooms, I'd expect a telephone call to immediately come to the rooms, or most importantly, probably most likely direct them to the emergency department of the relevant hospital. Here at St Vincent's, we're very fortunate to have a total campus with both the private and the public and the emergency department. And I'd ask this person to most likely be nil by mouth from when they leave their GP, and I'd take them back to the operating room and explore it and close it up, palpate digitally, just to make sure that there's no breakdown of the deeper arthrotomy sutures, and then just close it.
So when would you be concerned that this is not a simple traumatic dehiscence?
That there was no episode of trauma. That's the first point. Very rarely, but I have seen it. A really gung-ho male who wants to really beat everybody else in rehabilitation and to try to get the most flexion. It's rare, but it does happen. I've seen it once.
Yes, there's something I've seen where the patient has severe preoperative stiffness, and when we've done the knee replacement, we've achieved a marked improvement in range. We can even feel it when we're suturing the tissues, that tightness of trying to get the closure. And it's not hard to imagine that when the flexion is pushed post-operatively, that there can be that potential risk. And so sometimes we try to supplement the closure with, well, generally close it, put a glue layer on my patients anyway. But in those patients in particular, I might use a negative pressure dressing to splint and reinforce the wound a bit.
I think Horng's brought up a really good point, because I had a patient like this literally 3 weeks ago, an old Australian representative soccer player. He had a 25-degree varus angulation deformity preoperatively and 25 degrees of fixed flexion deformity, and only achieved 90 degrees. So he was concerning, and he was exactly as you described. He was tight. I did a subcuticular just absorbable suture, but actually reinforcing with staples. And because I just thought I had to put the belt and braces on this gentleman.
It's quite interesting. Preoperative stiffness is a key indicator for a range of postoperative outcomes. Certainly some of our mobility and range of motion outcomes, but in terms of skin and wound integrity, it's something that I certainly hadn't considered before. It's great.
So apart from wound issues, a patient comes to the office, we like to inquire about the pain and the mobility. And again, as we mentioned before, every patient will be different in terms of the analgesic requirement, be different in terms of the mobility progression. And the main concern would be when the pain had improved and then started getting worse again. Same with the mobility, that it was improving and then suddenly there's been a backward step. In those situations, when would you want to see that patient?
I always want to see everybody immediately because I'm paranoid. So excluding infection, I want to see that person, obviously to exclude infection, but the fact that they're going backwards is the important point to take tonight. So I'd want to...
What are some of the other things you want to exclude?
Fractures of soil. So with the hip replacement, look, there can be an intraoperative fracture which has been missed, particularly more proximally around the greater trochanter or around the lesser trochanter, or even distally. And as a result of that, it's been missed initially, and now as the person's up and going and increasing their activity level, they suddenly get increasing pain, and the fracture propagates, and there's now potentially loosening of the implant and subsidence of the implant.
And with a hip replacement, that patient can present with instability as well as dislocation of the hip, because the prosthesis has changed in position.
And it happens. It's less than 1%, but it happens.
Now, when we're talking about this before, John, you also mentioned that the pain can increase and the mobility can go backwards because of too much activity. We still want to see that patient to exclude these things: infection, fracture, periprosthetic fracture, or subsidence of the component. Next thing, we look more into the joint function. In the knee, we'll be looking at the range of motion. In the hip, there can sometimes be more specific soft tissue impingement described. John, can you talk to us more about this?
As you alluded to before, let's say knee replacement is progressing well and suddenly it stops progressing. It might be, let's say, at the 6-week mark, they've come back to see you. Maybe you've got a telephone call from Sean that say that they've haven't progressed and they're now 5 degrees of full extension, and they're at the 6-week mark, and they're also 90 degrees of flexion, and they really haven't progressed in the last 10 days. So that's fitness. Maybe someone who's starting to throw off a lot of scar tissue and may require a manipulation under anesthetic. At the same time, the person may have been like my other patient who's already had a fixed flexion deformity of 25 degrees and achieved 90 degrees. So, 10 degrees of full extension and 90 is reasonable.
As we mentioned before, the pre-op range is a big predictor of the post-operative range. In assessing stiffness after knee replacement, it's very helpful to know what their preoperative range is.
Now, I really like you. I mean, I love your talk, and I really like how you've broken this down. The instability is a subtle one here. So the instability is inference that the person was functioning well, pain was decreasing, function was increasing, then suddenly, well, the person can present with obviously a dislocation with the hip, but more so with, let's say, the knee. Suddenly, one of the ligaments has now attenuated or ruptured, and that could be an issue of instability. The medial collateral ligament, your retractors have gone in there, they've had this deformity, you've manhandled them, and there's now instability because the ligament has ruptured.
Yeah, I've seen something you've seen the patient before was presented. Well, they presented to me much later after having surgery elsewhere, but from what they described, so they've had a cruciate retaining type of knee replacement. Everything was going well. Subsequently, they had a stumble and a fall, and then there was increased pain after that. There was swelling, and this pain and swelling improved, but subsequent to that, they were never quite happy with the knee. The knee felt they felt like they couldn't trust the knee, particularly going downstairs. There's a hesitation to use that knee to go downstairs, and in that patient, what turned out to be that they ruptured the posterior cruciate ligament from that fall.
Yeah, definitely, and it does happen. Somebody's got a very happy knee, then suddenly it's unhappy 5 years later, and for that one mechanical reason. Tendinitis. The other thing is that when people get going, as Sean knows, what were they doing before? And then suddenly they're doing more, so they've got a bit of an overuse syndrome of both the quadriceps, suddenly really working hard to get in their full extension. They've been doing their half squats. The insertion of the hamstring has become irritable. I mean, that's quite a common situation.
Oh, most definitely. And exercise, certainly after joint replacements like garden fertilizer, you put too much on, you can kill the lawn, So it's finding that fine balance between patient compliance and not overdoing it.
The balance.
And again, we bring up infection here because when the joint is not functioning well for any way of presentation or any reason, we always want to exclude underlying infection as well. So John, I'm going to get you to go through in summary.
Well, this is the first part, which we developed the care plan, which is quite common for the general practitioner, but we think about it as pain, function, and the quality of life that the person is experiencing. And there are 3 things that we'd like you to take home regarding point number 1. Point number 2, I really did love the angry and unhappy and sad knee. I can tell you right now, Horng is always happy. And I think that was a really good breakdown for the practitioner to take away tonight to think about for the knee examination.
We've listed there the conditions that which would require referral and the sort of time frame.
And for a functioning knee which is going and which is going well, then suddenly just always consider. I think this is a really, really important part of tonight's talk, and I really like how Horng brought it back to how that person can present themselves to your rooms. Wound issues, pain and mobility and function. Just think of it like that. Forget about the anatomy. Just think of it like that, and it will come to you and objectively, so that you can go, yes, this is how is it going, what's happening. You were taking, X or Y pain relief, and now you've doubled that. Getting back to what Sean's doing, you've increased things, so maybe you're overdoing it. So I think the learning outcome for point number 3, which Horng has described, is outstanding.
Yes, we just tried to present a simple framework to assess or to approach these issues. So, but are there questions in this section?
Yeah, we do have a few last minute questions. So what is the protocol for NOACs post-op?
So can you repeat that again, please?
Sorry, what is the protocol for NOACs post-operation?
No,
I missed.
we missed that word.
Sorry.
Post-op protocol for
NOACs.
Okay. So so there's a variety of protocols for venous thromboembolism prophylaxis after joint replacements, and there's a variety of guidelines available, and surgeons do have different philosophies and follow different guidelines. So it is surgeon dependent. Now, not all of us will use NOACs, but commonly, say where rivaroxaban is used, a common protocol would be for 5 weeks after a hip replacement and 2 weeks after a knee replacement. Do you agree with that?
Yeah, I agree with that. 2 weeks for knees and 4 weeks, minimum 4 weeks.
Do you use rivaroxaban as your usual?
No, I do not.
Yeah, my usual protocol is clexane for those timeframes as mentioned before.
Okay, great. Do all patients post total knee replacement have a venous ultrasound of the leg before discharge to rule out DVT?
Yeah, again, there's a variety of protocols, and different surgeons will have different practices. I do not routinely have the patient have the venous tubercle prior to discharge. There are guidelines which suggest that it's not necessary. John, what do you do?
Well, I do, because St Vincent's is fairly vigilant in regarding taking into account the risk factors for thromboembolic disease. Obviously, major surgery knees and hips fall into the category independent of any other comorbidities. I take a look at it from this way. Yes, it's probably 5% that happens below knee DVT. Obviously, the level is what's concerning. So the knee and above is concerning, and we would want to treat that. I think about it for our beloved vascular physicians who may see the long-term problems or the chronicity of an unresolved and untreated DVT. So going back to your photograph with that person with poor circulation, venous return, you can see that they may have recurrent episodes of presentations for cellulitis. So even though the literature does not support having a surveillance ultrasound, I think for, you know, I've fallen in line here at St Vincent's, being a St Vincent's registrar and consultant of doing the duplex ultrasound, and I'm happy with that.
Yeah, so to answer that, there's no standard protocol, and there are different practices among different surgeons there.
Okay, and we just have one more question, but before I ask that one, I just want to draw the audience's attention to the chat box where we've dropped in the link to the orthopedic assessment video. That was the video that we had trouble viewing before, so you can access it there, and we will be sending out the link when we send out the evaluation as well, so you will be able to see it. And on to our last question. A patient has a subtrochanteric fracture of the right femur and history of right knee replacement and revision, and is now showing loosening of the long stem of the right total knee replacement. What would be your management? And this patient has chronic right knee pain.
So just let me get this situation right. So you said a revision knee replacement of the long stem, and that's loose and chronically painful, and he's sustained acute subtrochanteric fracture. Is that right?
That's right. Yep.
Yeah. So the question then is whether to to deal with them as separate issues, to fix the fracture first, and then deal with the loose knee replacement later on, or whether to try to attempt to deal with it all at the one sitting. So the operation would have to be tailored to the individual patient. Obviously, it would have to depend on their medical comorbidities and the general function and the exact fracture pattern. In terms of the surgery, it is much simpler to address the subtrochanteric fracture first and deal with the revision knee later. Now we'll have to look at the specific X-rays to be able to say what we would do, but to deal with it all at once. Again, we have to look at the X-rays. It would be quite a invasive procedure to try to do it all at once. It might be achievable, but we have to look at the specific details.
I agree with that. I think a measured response would be appropriate. I think dealing with the fracture first and the list tibial, the list knee replacement second would be my choice.
Yeah, I think it's so there's two ways to approach it, but it's very hard to give a specific response without seeing the patient, seeing the X-rays, because it has to be very tailored to that individual situation.
Okay, great. And I think that is our last question. So I just want to thank both of our speakers tonight for taking the time